Welcome panelists, welcome attendees. Welcome to the DHIT frequency and another episode of the Digital Health Institute for Transformation's podcast and web series, where game changers, status quo challengers, and health transformers come together to share best practices, new practices, and all else, healthcare and digital health. Today's episode is part of our continuation of the COVID Unites Us series. We'll focus specifically today on the advances, opportunities, challenges of remote monitoring in the context of COVID and the naturally evolving care models of value-based care. We'll talk about the need for personalized and otherwise known as edge data brought to you by advanced and emerging sensor technologies. And these technologies in their opportunity to impact not just COVID, but remote care overall and this post-COVID-19 reality that we're slowly but surely maturing into. And what infrastructure is necessary to support a future health system and a future care delivery system that perhaps doesn't look much like what we have historically had access and delivered against. So very excited about today's session. Before we introduce the panelists and kick off our session today, I want to welcome participation from the audience by utilizing the Q&A feature in this Zoom platform. I will, throughout the panel, pull in and integrate, if applicable, questions, but we'll definitely have time at the end to select a couple for the panel themselves. Additionally, there is a view options setting at the top of your Zoom to adjust how the video broadcast is displayed for you. We've had feedback to suggest the panelists were tiny little squares in the top right of the screen, and the slides were very large. So you can self-adjust. We cannot do that for the audience. So just a note there. Also, I'd like to, of course, send our thoughts and energy out to all those on the front line of this pandemic, those who are fighting every day to save lives, those who are fighting for their life, and naturally those who are affected and challenged to feed their families and to keep their roof over their head. Our thoughts and energy are with you. Also, I'd like to thank our sponsors who support our vision of a world without health inequity and a mission to maximize health communities across the nation and beyond by providing equal access to global advancements in care.
Thank you to our sponsors. Thank you to Blue Door Group, a leading digital health agency supporting growth and product innovation through customer and market insights. Thank you to Tango AI, a powerful human-powered neural net that is the optimal combination of human and machine intelligence to help people achieve the right balance between humans and automation to optimize outcomes. And finally, Smashing Boxes, a creative technology firm with a strong emphasis on the design and engineering of web and mobile products. Visit our sponsors today.
Thank you, sponsors. All right, without further ado, it's with great pleasure that I introduce our panel today, all of which I've had a lovely history with and built a friendship and advanced many conversations along the lines of this one. Never together, so this is the first time for us four. But kicking off, Dr. Ian Chuang, esteemed clinical informaticist, holding senior executive roles at Cigna, Cerner, NetSmart, McKesson, and today is global CMO for Elsevier Health, the market leader of digital information and analytic solutions that enhance the performance of science, health, technology professionals, empowering them to make better decisions and deliver health care. Thank you, Ian. Pleasure.
Thanks.
We've got Dr. Veena Misra, Distinguished Professor of Electrical and Computer Engineering and Director of the Assist Center at NC State University, which focuses on developing leading-edge systems for high-value applications, such as healthcare and IoT, by integrating fundamental advances in energy harvesting, low-power electronics, and sensors with a focus on usability and actionable data. Thank you for joining us, Veena.
Thank you.
And Dr. Michael Ruhlen, a human-centric clinical educator who's dedicated to training the future caregivers to treat the person in the context of who they are, not just what they are. Those are my words. He's director of the Charlotte AHEC, which stands for the Area Health Education Center, and the VP of Medical Education at Atrium Health, as well as the vice chair of the ACCME Accreditation Committee, and also our board advisory chair at DHIT. Thank you, Michael, for joining us as well. Thank you, panelists. Let's kick off. Look, we're now over a month and a half, 2 months into this pandemic. We've been social distancing for quite some time, it seems. The curve that we've been focusing on to flatten in some cases is states across the country and countries across the globe are starting to emerge with reopening plans. I'm not convinced we know whether that's a good idea or not. I'm not convinced we have the data that tells us any real truth here. Much of our data has been in the way of state level, country level, healthcare capacity, testing capacity, infection rates, et cetera. I don't see very much data from the ground level, from the individuals, from the context of our people. How can this be effective? What information's missing? What would be ideal if we could have data accessible to us to tell a different story, a more truthful or a more complete story, I should say. Mike, considering your vantage point as on the ground with Atrium Health and on the ground at AHEC, focused on driving information across your community as it relates, I'd love to hear your perspective first.
So let me set aside the system roles because they perhaps aren't even relevant to the discussion. I'm a pediatrician. I am not an epidemiologist, but I can tell you that I think the metrics that we're following are there because they are indicators of our healthcare systems' susceptibility to becoming overwhelmed with the volumes related to COVID. We talk a lot about peak incident rates is, I think, what folks are really following. Those are the new cases that develop on a daily basis or a weekly basis or a monthly basis. And because the population of folks that end up requiring hospitalization and then critical care and then ventilator care and critical care units is some proportional fraction of that rate, it's of concern to everybody because we started this adventure with a limited capacity in terms of critical care in the United States. For me, when I finally get out of my home and social distancing is lifted, the figure that I would like to follow is prevalence rate, which means those people that are actively carrying the virus and are capable of transmitting it. So I would like to know whether or not I've got a 29% chance of bumping into someone that can give me the illness when I finally get out of my home, or whether it's down around 5%, because my approach to getting out into society would be different. With respect frontline sorts of statistics, the site that I have followed really since there were only 2,000 cases in China is the dashboard that's been produced by Johns Hopkins and is readily available on the internet. And I think it's really interesting when you look at that, the incidence rate, the number of people who have acquired the disease in New York per 100,000 is 1,805 per 100,000. So that's a substantial load in comparison to North Carolina. I'm pretty grateful that I'm living in North Carolina right now, because our incidence rate is 106 per 100,000. And so what's the difference, and how could we have managed data to help us be even better informed? The incidence rate is a reflection of social determinants of health. It's also a reflection of the compactness of society. It's pretty easy to see how the folks in Manhattan might have been so closely packed against one another that the virus easily spread there. But there are many other determinants that we could have been following. We know, for instance, that there is a significant disparity in the attack rates between the Caucasian populations and any of the other underserved populations that one might consider. And the reason for that is that the incidence of chronic diseases that complicate COVID is higher in the majority of those populations. And that also is a reflection of poor access to care. It's a reflection of poverty. People who live in poverty don't have the opportunity to stockpile goods in their homes, probably can't afford to do that if they even wanted to try. And that means they have to go out into the environment on a more frequent basis to purchase what they can and come back into their homes. Those populations also have a higher prevalence in the service sector of our economy, meaning they're out there in the transportation industry. They are perhaps folks who provide some of the lower level services, even in healthcare systems. They're in governmental systems. And so they are in occupations where their potential for exposure is much greater. So if I had my druthers about this, I would like to have had a pre-existing opportunity to understand the social circumstances, social determinants of health of individuals in our populations, any of the chronic underlying conditions they may have. And certainly I'd like to have been able to ensure that those individuals that have conditions like diabetes were as finely tuned and in control as I could have gotten them to be as this wave of viral infection sweeps across us. And in particular, patients that have chronic obstructive pulmonary conditions, who have been smokers, who have asthma, all of the conditions that can predispose to the bad outcomes of COVID. It would have been useful to know about them, perhaps to have been able to have followed pulse oximetry remotely for those individuals, or had an opportunity to do a routine checkpoint with them. So that's what I would like to have if I had the opportunity to be better informed.
No, that's great. And really, I think, you anchored on the difference between reactive care and proactive care, or reactive knowledge and proactive knowledge, looking from a system being overwhelmed to handle and react to the spread of, to the use of data to be proactive. Ian, you've been in roles utilizing data, driving analytics and in the kind of vein of proactive and preventative health. What do you see, piggybacking on Mike's comments, what do you see as our greatest opportunity to kind of capture some of this data? And do you see right now any tools out there doing so at the moment?
Yeah, so I would concur with Michael in the sense that our reality is, how I classify it is, we've got good macro gross level data and insights, right? The data about the number of infections, the number of deaths and things like that, high level macro. But the bimodal distribution is also, we're getting good data for acute care, right? When patients present to the hospital and they are acutely ill, through our current digital systems and the care process, we're getting good data by which we can study and learn about that process. But like Michael, I'm a primary care as well. I'm a family physician, so I'm looking at this from the lens of an informaticist and as a family physician. And what people are asking me is the gap in knowledge and information in that middle, which is beyond the high level directives and best practices about, social distancing, hygiene, and self-care. What are the more personalized guidance that we as primary care typically provide? So for somebody with asthma or COPD, in context of their illness baseline, right? So not all asthmatics, not all COPDs, not all people with heart failures are the same. I don't know how to care for those individuals in context of COVID. What's the risk threshold for guiding them to seek care, right? So we have all these people with chronic conditions out there that have to make decisions and choices, provide continuous care. There's not good data that gives that insights and guidance. So we're doing our best in terms of providing virtual care to access that, but then that data gets siloed. We are not able to dive into that to understand more holistically and from a research perspective, what's working and what's not, what could be optimized when I can't put my stethoscope to that person's heart and assess. So that's the data or information gap. I think the data is there, but they're all in information database silos. One of the things that's interestingly going on, talking about the social demographic, is to collect more of the realities of our biometrics to understand baseline, because right now our symptom-based identification of risk of COVID is relatively crude. It sounds like a cold, it sounds like a flu, it sounds like sinusitis for the average consumer. So it's not very specific. So one of the things I'm participating in is a study through University of California, San Francisco, in partnership with Aura, which is basically a monitoring device that through a ring. So we're trying to basically get some baseline biometrics that gets us to understand what's our norm. It turns out my normal temperature is about almost half a degree to 1 degree lower than what is typically average, right? So the problem with average is half the people are too high, half are too low. But now to understand that's my baseline and I'm right now symptom free, that can help inform when that elevated temperature becomes more meaningful in context of my normal baseline. So I think those data will be coming, but that's a lot of full court, full press effort right now to try to learn more about what we're experiencing and how do we be better at detecting those individuals at risk in the community.
And this, obviously we're focused on COVID and this pandemic today, but is this not just a representation of the care gap or information gap that has historically existed from a health system perspective when you look at chronic disease, et cetera?
I think it's identifying and accentuating many gaps, right? Right now, our healthcare model is very disease-oriented. It is more of a reactive, meaning I as a patient need to put up my hand and say, I don't think I feel well. And then we have to proactively request an appointment. The appointment typically is into the future, especially in the office setting, right? So it's not really patient-centric in its design. So whether it's access, whether it's the mode of care, which is all geared around face-to-face, and whether it's based on data that's partly subjective through our assessment, history and physical, partly quantitative. I think because of the constraints on face-to-face, it's forced us to figure out as clinicians what is doable through virtual care, whether it's telephonic, telemedicine, or through chat. So we can basically guide individuals, both in context of COVID, right, screening them, triaging them, but also in terms of, I can't see my chronic patients, so how am I going to still take care of them when I don't have the benefit of a face-to-face office visit? Yeah. The reality is, it turns out, if I've got an established patient, a lot of the time it's around treatment, optimization, and management, and between a good understanding of baseline, access to historical information that's now available more easily through EMRs, and then some biometrics. Right now, I can do a 6-lead EKG on my own self with a little cardio device. I can do O2 sat through my Samsung phone. I can do my self-measuring blood pressure. So the data may not be integrated, but definitely we could rely on more self-measurement data plus virtual communication.
So, I mean, it seems, look, both you and Mike both anchored on the criticality of individual data streams, behavioral data, social, environmental data. Veena, give us an example, considering your specialty in electrical computer engineering, the assist center's focus on sensor technologies, specifically self-powered low energy systems. What are you most excited about now? Now that the market, in a lot of respects, is maturing to the point where the need and the focus of these technologies is meeting the opportunity that the technologies deliver on.
Yeah, thank you. So I think the current situation has really made it obvious that remote digital monitoring will be a reality for most of us going forward. What makes me really excited is to hear some of the comments by Ian, where he's talking about baselines and looking at information that's actually related to the individual. So for example, in our center, which we are building these battery-free, always-on wearables, primarily to be able to enable long-term monitoring. And the reason for long-term monitoring was best described by Ian, where you really want to know an individual's change of their biometrics and compare their changes in baseline heart rate to what they had maybe 3 months ago versus just some average. And so the kinds of things that we're developing in our center are precisely things like heart rate variability, oxygen levels, skin temperature, of course, activity, and looking at trends in activity over time. And also another important point in all of this is the role of environment. More and more studies are coming out right now where pollution might be connected to transmission or maybe even the severity of infection. And so that's something else that we have been working on in our asthma platform in our center, is to in real time monitor air quality and then look at the response of respiration based on air quality. And I think some of those kinds of platforms could perhaps be useful in this situation where it has been reported, for example, that in Italy, the rates of pollution are very different than in other parts, and there may be a connection there. So I think, yeah.
Sorry.
Also, I wanted to mention that we have some technologies that have been spun out. There's a company, Dermasense, that is looking at microneedles. And I wanted to also mention that there are huge opportunities there where you can look at antibodies in interstitial fluid instead of blood. And they just had an IRB that has been approved with neurosynchrony to work with the microneedles on that. So I think the solution hopefully is in big part going to be helped by technology and accuracy of this technology, so the doctors believe the data.
So to that point, Mike, you're thinking about the education and the training and the maturity of our physicians and our caregivers every day. And I can only imagine you're sitting in a position where the challenge of reorienting, how we care for individuals, both today in this pandemic, but over the imminent future, what do you see as the core challenges from a caregiving perspective, from an educational perspective, to train up and upskill our practitioners, our providers of care to these technologies, to remote care overall, and these data streams that will inevitably become more and more available to us?
Hugely interesting question. So first of all, let's consider, if Zoom is a publicly traded company, I wish I had purchased stock in it a long time ago, because I'm thinking about the nearly immediate adoption of Zoom across our society as a major platform for communications of this nature. That happened nearly immediately overnight. There were a variety of platforms out there, but Zoom has a pretty high quality offering, and those of those organizations that had already been using it, and DHIT is one of them, pretty much understood the capabilities. Quite a number of others did not. But that change in just communication technology is emblematic of some of the things that have happened in medicine as well. Nearly overnight, all healthcare providers who knew how to do it already, all those who were just about ready to pull the trigger, those who hadn't thought about it yet but figured out they needed to do it, started jumping into the telehealth space. And as Ian pointed out, there are a number of venues for that to happen. Telemedicine in the form of a video contact with a patient seems to have been a popular outcome. We also jumped into the rapid deployment of many Internet of Things devices. And I would say that the education gap among providers is that I think we have tended to become attracted to the bright, shiny objects that get presented to us. And in the face of this emergency, we've adopted quite a few technologies for remote monitoring that we might not have jumped so quickly to move on had we not been presented with the COVID emergency. And by that I mean we don't necessarily understand the technical limitations of some of those monitoring devices, whether or not a robust internet connection would be necessary in order for them to function properly. What happens, I'm speaking to you from a place up in the western North Carolina mountains, and I'm fortunate to have access to a high-speed cell tower here. But there are many of the folks who live behind a mountain in this immediate region who don't have internet services at all. And so it's easy to jump into the assumption that we can provide care for nearly all of our populations based on internet and connected technologies, when in reality, we have a fair number of people who, for reasons of geography here and for reasons of poverty, don't necessarily have connection to high-speed internet and any devices that would be connected to them. So I think one of the things that healthcare providers really need to understand, and there's a body of information that we can develop and start talking about, is the limitations of IoT devices, the promise of IoT devices. There's been such extraordinary innovation in that field, and we've talked about a number of ways that patients can be monitored in their own homes. We've added the communications layer with technologies like Zoom. And I think the other part of it is that in about 2016, the FDA started talking about the cybersecurity aspects of devices of this nature. There are undoubtedly some platforms that have been deployed at this point that probably have cybersecurity attributes that haven't been fully secured. And we also know that at this point, there have been reports of people already trying to leverage the huge national interest that is COVID to help cover some of their perhaps phishing attacks on healthcare providers in their workplace by sending emails to health systems that can launch a phishing attack, or to otherwise go after data that might be involved with IoT connected things. So I think there's a body of information that we also need to be conveying about the data integrity pieces of these devices, about the cybersecurity aspects of them, and then to absolutely make sure that people understand the full utility of this sort of technology.
I would like to echo one thing that Mike did make, and that is around what's being accentuated through our experience right now. So just like healthcare, IoT, digital technology is not evenly distributed amongst the population. So as much as we are seeing the advancement and the digital transformation, we also have to address the system at the macro level, because it has a similar pattern as healthcare access and quality and all those other issues. So it's not going to be evenly leveraged, evenly accessible, and the benefits won't be evenly distributed across the population.
Yeah, and it seems to, really anchor to the point of, kind of where we're seeing the greatest rates of, prevalence rates in the socioeconomically, let's say misfortuned and disenfranchised, where the need is, right, and where the have is disconnected. Veena, are you, when you're developing technologies and you're looking at systems of technical delivery, does this cost, does it access come into play in your center? If so, how?
Yeah, delivering these technologies, I think, help in leveling the playing field as long as they're low cost. So if you can provide these basic parameters of health monitoring at a rate that's low enough for people to afford, or get the insurance companies involved, I think that'll help the entire ecosystem. So we are always cognizant of the materials that we use, or the cost of the technologies that we're building, and we are working with our member companies to scale up these technologies to further drive the cost. So, Michael, we are sort of a research spin out. We develop technologies and we spin them out to companies, and then we work with our member companies to drive them into the commercial space. So yeah, cost is absolutely a case, but not only the cost, even the technologies that we use can be connected to different populations. So you have certain technologies that work well under certain environments. In other cases, you don't. For example, if you don't have the bandwidth, the proper internet bandwidth in rural areas, you need other ways of getting the data. If you have individuals that are perhaps different body types, or they are obese, or they have other chronic issues where they can't wear a particular type of device, you have to adapt to those needs as well. So absolutely, I think that's a critical piece.
So Mike, I can imagine, that type of, just right there, what Veena articulated in terms of almost a decision tree assessment of understanding, who, what technologies are relevant to whom, and how a provider or a clinical system evaluates and distributes technologies based off of the communities and individuals they provide care to.
Well, it seems to me that actually access to internet services should be included among the social determinants of health, because it's becoming so important in our society at this point, and it needs to be a checkbox in the electronic health record, I think.
Yeah, it makes sense. Ian, you have a global perspective here as both a Canadian from familiar with the Canadian health system, but naturally in your role at Elsevier as a global CMO, looking at different countries and places of care delivery that are perhaps either more advanced or alternatively advanced as the U.S. from a technical perspective. Are you seeing anything that's working, that's different to service the socioeconomically disadvantaged or the vulnerable populations that we can learn from?
Yeah, that's a great question, because that's one of the unique learnings that I continuously have now in my role being a global chief medical officer, is basically having access and seeing how medicine is practiced to meet the localized geographical needs of population. And it is very diverse, right? So as physicians, clinicians, the body of knowledge core is we draw from the same core, but how we apply it has to be adapted. And in some of the other countries where either because of population size and density exceeds what we have to deal with and cope with in the US, requires a whole new different set of thresholds for quality and process outcomes, and also how you approach care. So, the concept of reverse innovation is in these more challenging environments, the level of creativity to solve harder problems with the luxury of a big budget, right? So those healthcare systems are commonly universal. They're not commercialized systems based on for-profit driven, not necessarily. But the focus then becomes, how do I do the best and the most with a limited level of resources? So ironically, I see the digital use cases much more easily accepted by clinicians and much more readily adopted by the population. So whether it's scheduling through an app, because you can't have 1,000 people waiting in the emergency room, right? So 1,000 is the daily volume for an ER in some of these hospitals, where in ours it's maybe a few hundred, right? It's an issue of scale. And then pushing patients through, accessing them in remote areas, a lot more reliance on digital technology as a way to communicate, all the way through to a mechanism for payment. So, WeChat and WhatsApp is almost universally used in other countries, and it serves multiple purposes, including transaction, including sending data. And they've gotten okay and comfortable in that sort of parameters of privacy and data security, because the need exceeds the concerns and other limitations. But that's what I see is how do you adapt to meet the need when you have limited resources, limited funding, and a really big demand.
Thank you, Veena. You're really at the forefront of the technology maturity curve and challenging daily what technology could look like to do a lot of the things that we're talking about right now. Let's fast forward 5 years. Assuming we mature from a health system perspective, and both from a provider in care delivery to a consumer patient adoption, what technologies are out there that we're going to be utilizing? Are we talking about smart Band-Aids that we put on to measure our lactate? Are we talking ingestibles what give us a sense of what could be in 5 years?
Yeah, that's a great question. I think standard measurements like continuous heart rate or continuous oxygen levels or blood pressure as needed, I think those are going to become mainstream is what we see. But there are so many more things that can happen. For example, continuous monitoring of biomarkers in sweat is a huge opportunity. Lactate, for example, but there are many others inside sweat. For example, neurotransmitters that might be released in sweat. There's a great interest right now in the actually in the COVID community on neurotransmitters and how they are modulating during infection. But I think there are also other opportunities in terms of social interaction. For example, if the pandemic is requiring us to not transmit the disease, is there anything we can do to mitigate infection or transmission? And we've thought about smart masks, for example. Are there things that the mask can be printed, like electronics that can be printed on masks at a very low cost? Are there things that we can do to kind of create a minimum distance between individuals to minimize spread? There are things where you can also look at other locations on the body that are not at all obvious, because a lot of people don't want to show that they have any kind of device on, that can also monitor quite a few things. And then there's the whole direction of injectables, where you can inject small amounts of very small, tiny sensors just under the skin, and they can provide you constant monitoring of, let's say, oxygen levels. So there's a huge window of opportunity with devices that are currently being built. Of course, it takes time to mature them and confirm their clinical validation and so forth, but these are all on the horizon. So I'm excited about what's coming up next.
Mike, Ian, as clinicians, I can imagine, and that caring for your patients and populations with this type of continuous longitudinal data is pretty exciting. What do you think is necessary to support this type of care in the future from an infrastructure perspective, from regulatory? I mean, Mike, you spoke about privacy, cybersecurity, but what about payment models? What about incentives and motivations of the patients themselves and the systems of care around? What infrastructure is missing that we need to think about? Mike, Ian. Ian, we'll kick off with you.
So let me start with the utility of the data. It's both an opportunity and it's going to be a daunting challenge because we may be pushing hard for this thing called big data, and right now there's more data than we know how to use well. Really, we want information, and what Mike said, information in context, right? A blood pressure reading has to be understood in the context of what the person is doing, the environment they're in, the medication they're on, et cetera, et cetera. So that being said, I'd rather have data than not, but it's going to have to be a process based on research, based on consensus and guidelines about what's the value of it. There's a bunch of us that we call, the quantified individuals, quantified self, right? We have more data about ourselves just purely out of curiosity. My wellness visit to the physician now isn't so much about a physical exam. It's literally, I have a bunch of data. So what Veena mentioned, I have my heart rate through rest, through sleep, as well as through exercise. I do long distance rides. You can see my heart trend over time. That's more data than my doctor has the ability to store, because it's not easy to get my data from Samsung into the EMR. And two, really, each data point is not as valuable as the impression he gets out of it and helping me understand that my normal baseline is this. So this is what we will use to decide if, blood pressures, et cetera, becomes abnormal. So that's right now experience-based. We have to consolidate that and make that into a shared research-based, evidence-based approach. And then we have to guide the broader clinical community and then figure out how to use it. So I wanted to comment on that because we've got a lot of data already. They're all in the silos though. And then we have pockets of people who just like to use it. They may be the worried well, but let's learn from that. Let's understand what can be applied and how to use it.
I think if I can jump in real quickly, I think the other opportunity here, going again to the data piece, is creating new correlations between different data streams. Mm-hmm. And that can create a whole new sense of perhaps understanding that we don't have right now. So these digital biomarkers that maybe connect the heart rate to lactate or some other sensors that we're collecting data, just looking at the data differently.
Yes,
I think is an opportunity.
Mike, anything to add?
Yeah, my thought was human beings have a limited capability to evaluate multiple variables at any one point in time. And I think the number that kind of sticks in my mind is that by the time we get past about 7 variables that we're considering all at once, we kind of fall apart and we don't make reasonable, cogent decisions based on what we're viewing. So if you look at the data services available to clinicians nowadays, the electronic health records are frequently cited as one of the major reasons that physicians burn out. It has to do with keyboarding. It has to do with interposing digital devices between physicians and their patients. It has to do with alerts that pop up that may or may not be relevant to a given clinician's clinical environment or concern with a patient. All those things begin to interfere with the patient-physician exchange. And so in my mind, the way I'd sum up this discussion is we really got to get some artificial intelligence hammered out. And instead of just representing collections of different data points to our clinicians, starts to give insight into those data points and does some of that consideration of the multi-variables taken care of in the background so that doctors can get, and nurses and all clinical staff can get back to the core human interaction that is the rendering of medical care.
Yeah, that makes perfect sense, and ideally, an ideal situation, human interaction with the support of extreme intelligence, delivering insight to deliver better care. The point around AI, it brings up our trust in AI and our cultural acceptance to failure in a computer algorithm versus a failure in a human, let's call it human intelligence. I read an article, I can't remember the source, but it was speaking about where we are from a radiology perspective and being able to deploy AI on top of, I believe, CT, breast modality, breast MRIs, and that we had something of about 95% success rate in the evaluation of the MRI scan. But there was a bit of an issue with the acceptance of a 5% failure rate, and what happened, and what happens, and who's to blame, and how do we culturally, kind of react to when there's failure and there is no human being to blame, so to speak. Do you see these types of challenges being part of our roadmap in the coming years of really kind of orienting around policy and procedures, regulatory frameworks to support AI and how we manage AI? Mike, Ian?
I'll jump in on the clinical care aspect of it. I think if we think of AI and in your example, that it's an augmented decision support, that we're not just turning something on and making that be the decision maker, but it can definitely reduce a lot of the volume of repetitive, detailed work. And the detail is looking at shades of gray. So I think a computer is better at sensitivity in that regards. So if the science around imaging reading gets better because of technology, we can actually improve the art aspect of it, right? Medicine's always been art plus science. And the art is really making the connection and understanding, which a computer can't do, right? If you tell me this thing from an imaging of gray colors on a pixel, and I'm looking at the patient, someone's got to make the judgment of whether that makes sense, right? So this is not definitive, and at 95% accuracy, that clinician can do that fine tuning. And even for the rest that are accepted as accurate, I would still suggest a little quick pass by clinicians, because you got to look at the patient and does it make sense? So if we augment instead of just saying we're replacing people, we take baby steps.
Yeah, I would have thought that most of these things will roll out maybe as about an 80-20 rule, that about 80% of the time, the simplest stuff can be taken care of by artificial intelligence or computer-assisted decision-making processes, and pretty much by regulation, because that's kind of the way it works. 20% of case material will require a human oversight. By the time we get to the 22nd century, we may have enough confidence in AI algorithms that at that point you get out the transponder and you wave it up and down at the patient and you get your answer. But that's a long time coming.
No, fair enough. And as we evolve here, and I'm just going to be pulling from an audience question. The role of public health. The role of healthcare delivery in America specifically. Do you see these becoming somewhat convergent, and do you see a potentially new system emerging where there's no difference between public health and healthcare delivery? Mike, I'll start with you.
Um, you know, I find that to be interesting, and it's going to involve some of the privacy issues that perhaps I was alluding to earlier. I had an opportunity to look at a news broadcast regarding the protests in Raleigh over the social distancing requirements in the state of North Carolina. And one of the protesters talked about that basically said, well, you know, when we run out of food, we're just going to eat healthcare workers. So that whole process, you know, there were some healthcare workers out there doing a counter protest, and there was some anger directed at the healthcare workers. When we get to the point that AI is good enough, that we know enough about individuals and their social circumstances and their healthcare issues to start talking to them about guidance, the real question is how much people will accept that. Will they accept it, or will they want to eat healthcare workers at that point? The question would be, Michael, you're my patient and you come in to visit me, and I say, you know, Michael, been talking to you about your cough, and I've been trying to convince you, but I have a Affinity card that comes in from your purchase history that says you're still purchasing 3 cartons of cigarettes per month. So we really need to talk about this. And I guess my premise would be that under certain circumstances, patients still like to maintain enough distance from their healthcare providers that they kind of like to lie to us yet. I'm doing everything I can to quit smoking, Dr. Ruhlen, says Michael. And so, again, there are going to be some privacy concerns that counterbalance all the opportunities that more robust information provides us.
Another disconnect that may be getting better because of COVID is the disconnect between what typically is public health, which is population centric, right? It's looking at the greater good at the population versus the medical care, which is more of an individual. But recognizing that it's really on a continuum. So we're seeing that public health is the canary around risk to enough people in a population, and then prevention strategies, whether it's vaccinations or other public health initiatives. I think what the consumer and the public doesn't know is how that connects to their own personal health and well-being and their medical care. So at some point, if this becomes less of, well, it's public health over there, and then if I get sick, I go medical care, it's really about health and well-being on the continuum. And what we know now, the bigger determinants of health and well-being is not in the doctor's office or in the hospital, it's out here.
Right.
How do we make that more visible, more personalized, so we can make that messaging is because of this will help you and your family for your situation, because you have a unique set of genetic risks and social and contextual and phenotypical issues. That's why this is relevant.
Yeah, and Veena,
I wanted to jump in.
I mean, this tees up beautifully for the Assist Center as it relates to both the individual data and the systems to connect and augment and deliver a somewhat connected tissue. Do you see it the same?
Yeah, that's right. In fact, there was a study that was published in Lancet this January on a very big study. I think it was 47,000 individuals where they had Fitbits. And they were able to predict or forecast the location where the flu was starting to grow. And so these are personal wearable monitors, which are providing personal health, but the same information was being used to understand public health. So I think those two go hand in hand. But I think there are some other maybe unique opportunities for people developing technologies that I think may be worth just looking into a little bit. For example, right now, how do you tell if somebody is walking around in the park or in a bus that has fever or something like that? You need some scalable ways to sense individuals that are sick. Blood tests are very slow and limited. So there's, for example, in the news the other day, I saw an article where a dog was sensing patients who had COVID or there's some connection there. We don't fully understand it. But scalable ways of picking out hotspots and even individuals, I think there might be some new things that might happen there.
Well, thank you, Veena. Thank you, Mike. Thank you, Ian. We're coming to the close of this wonderful discussion. Truly appreciate the perspectives, the insights, and the day-to-day energy you provide to, answering or asking, really tough and challenging questions and working your tails off to answer them. I truly appreciate it. Thank you for being with us at the DHIT frequency. I'm going to close down with a couple of housekeeping points. Number one, thank you again to our sponsors, Blue Door Group and Tango AI and Smashing Boxes. Truly appreciate the support and both the mission and vision of DHIT as well as our DHIT frequency series. Our next DHIT frequency session is May 15th, and I'm excited to announce in partnership with the Assist Center, Veena's group, we are going to focus solely on the very advanced and emerging technologies out of the Assist Center on the 15th. We'll hear from about four or five faculty members out of the Assist Center from smart wearables to textiles to metabolic sensing, et cetera. And that will really kick off a much longer partnership with the Assist Center that we'll announce here in the coming week through the DHIT Digest first and through various channels else, which really is going to be action oriented. It's a virtual incubator that we're joining forces with DHIT, with Assist Center with, and utilizing a crowdsourcing innovation platform called Crowdicity to bring offline and online opportunities for the ecosystem to engage, respond to challenges brought forth by the community and by COVID-19 specifically, utilizing technologies and other means to mitigate and fight this pandemic. So stay tuned for that. Again, May 15th is our next episode. Truly grateful, honored, humbled, Mike, Ian, Veena. Thank you for being part of this session. Have a wonderful day. We're signing off now.
Thank you.
Thank you. Bye-bye.